Hello everyone, welcome to BrainMap. This seminar series is co-sponsored by P41 funded Center for Mesoscale Mapping, housed in the Martino Center. It is our great pleasure to have Dr. Darin Dougherty today to give us BrainMap talk. Dr. Dougherty is the Director of Division of Neurotherapeutics within the Department of Psychiatry at Massachusetts General Hospital. The division encompasses all surgical and/or device-related treatment for psychiatric illness, including electroconvulsive therapy, ECT, transcranial magnetic stimulation (TMS), transcranial direct and alternating current stimulation, vagus nerve stimulation, evaluative limbic system procedures, and deep brain stimulation (DBS). In addition to providing clinical care with these technology, the division is deeply involved in research to better refine existing technology as well as in developing new technology such as closed loop or adaptive DBS. Dr. Dougherty specializes in mood and anxiety disorders and has published over 200 scientific papers, including clinical trials and neuroimaging electrophysiology studies. I would like to remind our audience to address their questions by raising your hand or in the Q&A box at the end of the talk. And thank you very much for giving us talk today, Dr. Dougherty, and the stage is yours.
Great. Thank you for the kind introduction. And I look forward to speaking to the Martinos Center. I'm based at the Navy Yard, so I know the Martinos Center well and have used its facilities for years. I use neuroimaging, but I'm not a neuroimager per se. I use it, again, to kind of assess how the treatments I'm going to talk about can be refined or developed using neuroimaging techniques. So I'm going to go over today a little bit about device and/or surgical related treatments for psychiatric illness and show how we've used neuroimaging to help refine these. And my hope is just to give you guys an idea of what's going on and how the tools are being used in research and clinical practice, and also potentially simulate some ideas for potential collaboration. So I do have disclosures. I have a research grant, and I have received honorarium from Medtronic. That is the company that manufactures one of the DBS devices. The others are not relevant to this talk, advisory roles, and then I have some equity in 3 startups. All right, so I'm going to start. We're going to talk about how we impact the circuitry underlying psychiatric disorder. So I thought I'd give a very simplistic overview of the 2 main disorders that we treat with these interventions, major depression and OCD, and what the neurocircuitry looks like at a gross level. This really is an amalgamation of what neuroimaging studies have revealed about the pathophysiology of depression. You can see in red, that's a ventral compartment. It includes the subgenual cingulate cortex, the insula, the amygdala. This area tends to be hyperactive, thus red, shown in red, in patients with major depression, both at rest and when you do emotional behavioral task. Conversely, the dorsal compartment, represented in blue, including the dorsolateral prefrontal cortex, areas of the cingulate cortex, tends to be hypoactive at rest and also hyporesponsive to cognitive task. That is compared to healthy volunteers. We know that successful treatment changes that. So you can look here at the 6 weeks. The 1 week's not so important, but after 6 weeks of treatment with fluoxetine, Prozac, you can see that there's increased activity in the dorsal compartment that was previously hypoactive, and lowered activity from baseline in the ventral compartment, which previously was hyperactive, as you recall. And you only see this in patients who respond to medications. The non-responders, this doesn't happen. So it appears that normalizing that balance is crucial for successful treatment of depression. Current model for OCD, there are a lot of cortical, striatal, thalamocortical circuits in the brain that observe multiple functions. There's even one circuit, for example, for ocular motor movement. There's a particular circuit called the ventral cognitive circuit that's hyperactive in patients with OCD, all of the nodes within it. And these are those nodes. The cortical node is the orbital frontal cortex. The striatal node is the head of the caudate nucleus. And the thalamo node is the dorsal median nucleus of the thalamus. And that's hyperactive at rest, and also if you provoke symptoms. And as we see with depression, successful treatment, you see the hyperactivity in the circuit decrease. So that gives you an idea of the anatomy that we're trying to target with these different stimulation and surgical approaches, which I'll talk about right now. So here's what we do in psychiatric neurotherapeutics. It's all surgical and or device-related treatment. It includes the old standby that's been around for 100 years, electroconvulsive therapy or ECT. It includes transcranial magnetic stimulation, another non-invasive approach. And it also includes invasive approaches that require surgery, like vagus nerve stimulation, which I'll talk about. That surgery is extracranial, not in the skull, but also intracranial procedures where you do go into the skull. And that can be lesions or implanting deep brain stimulation electrodes. So ECT has been around since the 1930s. Like I said, it's almost a century old, and it remains the gold standard treatment for TRD. It works very well. 60–70% of people do well with it. And there have been numerous, it's been around for so long, you can imagine, there have been numerous meta-analyses showing that ECT is more effective than sham, of course, but it's also better than medication, another medication trial. And they've also found that bilateral ECT is more effective than unilateral ECT. You can look at my picture here. Unilateral is like this, the two paddles, and bilateral is like this. We usually start with unilateral because there are cognitive side effects, as shown here in the third bullet. 50% of people might have some memory problems, usually around the time they receive the ECT. It's not like it erases memories from far before. But that is problematic for people. And we know the bilateral ECT increases the odds of that. So if we can get somebody well with unilateral, that's great. But we know we can move up to bilateral if we need to. Patients who do well, like I said, 60–70%, but many of them require maintenance ECT, where we have to do an ECT session every 2 to 4 weeks to keep them well. The acute course is usually 6 to 12 treatments, 3 times, it's three per week. So that's 2 to 4 weeks of 3 times a week. Talk a little bit about VNS therapy. This is vagus nerve stimulation. This is what it looks like. I'll use my cursor here. You go to the left vagus nerve and do an incision in the neck folds, open the carotid sheath, and there's the carotid artery, the internal jugular vein, and the vagus nerve. Tease out the vagus nerve. I don't do this, of course, the neurosurgeons do. And then they implant electrodes around the vagus nerve, as you've seen here. We always do the left vagus nerve because the right vagus nerve has parasympathetic branches to the heart, and we want to avoid that. Here's the vagus nerve coming into the brainstem, and it activates nuclei in the brain, the dorsal raphe and the nucleus, the locus coeruleus, which release serotonin and norepinephrine, respectively, much like the SSRIs and SNRIs affect serotonin and norepinephrine. In addition to that, it also does affect the circuit that I showed you earlier, and I'll show you some imaging data supporting that. It was approved by the FDA in 2005 for TRD. It didn't meet its primary outcome, but secondary outcome measures were so powerful that they improved it. And I'll show you some data on that in a second. However, because it didn't meet its primary outcome measure, it's been very hard to get insurance coverage for this. CMS, which is the part of Medicare that approves treatments, recently funded a pivotal trial, 500 patients for VNS. It will read out in May of 2024. And if that's positive, I think insurance coverage will be much easier to get. This is what the data looks like at 12 months. The active versus sham, back in the early 2000s, they only did 8 weeks of active versus sham, which in hindsight is much too short for VNS. We realize it usually takes 3 to 12 months to work. And this is 12-month data. You can see response. This is HAM-D is a clinician-administered scale. The IDS is a self-report paper pencil scale. But you can see response for people who received VNS, which is orange. was 30 versus 13. These are patients who just had treatment as usual and no VNS. It wasn't turned on. And you can see it's 30 to 13 and 22 to 12. And remission is very low in treatment-resistant patients. To be eligible for VNS, you have to have failed to respond to 4 antidepressants. And there, you can see what the remission rates look on a fifth or more antidepressant. Only 4 to 7% of people will remit. But with VNS, it rose to 15 to 17. Still not very high, but it is, 2 to 4 times what you see without VNS. We'll take it. If we had a chemotherapeutic agent and only had a 4 to 7% remission rate, and we found one that was 15 to 17, we would keep it. So I'm hopeful that the CMS trial will allow patients to have more access to this. We also published a VNS registry study, which was post-FDA approval. The FDA mandated it, where we followed people with VNS for 5 years and compared them to people who were also treatment as usual. That's what TAU stands for. Sorry. So they were just getting medication adjustments, whereas the VNS group was getting medication adjustments plus VNS, and followed 795 patients for 5 years. You can see the VNS arm is the orange. This is the cumulative percentage of patients who responded. We're getting response rates at 5 years of almost 70% compared to 40% for treatment as usual. And for remission, response is 50% or more reduction in symptoms. Remission means you're asymptomatic. So all remitters are responders, but not all responders are remitters. So the remission rates were above 40% as compared to about 25% with treatment as usual. And there have been scans looking across time, what changes with VNS, and these are, the red shows decreases. And here you can see that familiar pattern here and on the frontal lobe here, the orbital frontal cortex, the subgenual cortex, we see decreases with VNS, which one would expect and we see with other treatments. RTMS is transcranial magnetic stimulation. Neurologists often do single pulse TMS simply to measure nerve conduction. RTMS is repetitive or rapid, the R can stand for, where we deliver lots of pulses. It uses a magnetic field, I believe it's about 1.5 Tesla on the scalp surface that goes around, and it generates an electrical current on the brain surface. It only goes about 1 or 2 centimeters below the coil, usually. I'll show you an H coil in a moment, but the usual figure 8 coil. So it really is mostly, by the time it gets through scalp and skull, you're hitting gray matter on the brain surface. It doesn't require general anesthesia or induction of a grand mal seizure like ECT does. So it's much easier to use. People can come in, get a session, they're wide awake, and go back to work if they want to. It's currently approved for use for depression and OCD. This is what it looks like. You have a coil, magnetic field goes this way, you get an electrical current the other way. Of course, we don't really use the single coil because the electrical field looks like a crater, but we can use a figure 8 coil where the charge goes around like this, and right at the intersection of the loops, you get a nice peak of electrical activity. So you can target anywhere you want on the brain surface. And we do thousands of pulses in about 40 minutes. Their trains, they get like 3,000 to 4,000 pulses in 40 minutes. And it's loud, the patients have earplugs in while they're doing it, but otherwise it's very well tolerated. And the pulses are loud. It goes, and there's a break. You do that for 40 minutes and get your 3,000 to 4,000 pulses of energy into the brain. Initial studies were pretty small when it was first being developed, but the second bullet point is the most important. There was 2 large multi-site trials, one sponsored by a company that makes a TMS device, Neuronetics, that had 300 patients, and another sponsored, I think more importantly, independent by the NIH, which included almost 200 patients. That supported positive outcomes for RTMS for depression. It was approved by the FDA for depression in 2008. And then deep TMS, which I'll show you in a second, is another type of coil, was then approved in 2013 for patients with depression from a pivotal trial of 230 patients with treatment-resistant depression. That's what TRD stands for. OCD, multiple targets have been explored. For depression, we target the left dorsolateral prefrontal cortex excitatory, usually. There are other things you can do, but I'm not going to go into the weeds, but that's what's approved by the FDA. If you do that depression stimulation on the left dorsolateral prefrontal cortex for OCD, it's not efficacious. So trials have looked at different but similar targets that have had some efficacy, the dorsal medial prefrontal cortex and the pre-SMA. And since then, here's the BrainsWay Deep TMS device. So here you can see this is kind of like a beauty parlor helmet instead of that figure 8 coil. It has a coil that's shaped like an H, and it delivers a deep conical stimulation deep down into the midline. And I mentioned it was dorsal medial prefrontal cortex and pre-SMA. So you can hit all of that with the deep TMS system. And it was approved in 2018 for OCD. After 6 weeks of treatment, active versus sham was statistically significant. And you can see the responders, 38% versus 11 were responders, and 55% versus 25% were partial responders. So we have access to that now. Given that TMS is effective and we do it for 40 minutes a day, we published this 10 years ago. But we decided to deliver stimulation to the left dorsolateral prefrontal cortex 24 hours a day instead of 40 minutes a day. And what we did there is we had to surgically place basically an ECOG grid on the left dorsolateral prefrontal cortex. So we did a surgery and put the electrode here. This is from a tinnitus trial, so we put it up here. That's what the electrode looked like. It was basically just an anode and a cathode. And they have a wire under the skin that goes to a pacemaker that's under the skin that has the power and the microprocessor so that you can program the settings of the amplitude of what the electricity that's delivered. And we did an active versus sham for 8 weeks and then a long-term follow-up. So we targeted the middle of the inferior sulcus, the middle frontal gyrus. This was epidural, so we didn't go through the dura, so it was best guess, and that will be important later when I show you a slide. And this is what it looks like. So this is the TMS target where the electrode is placed. This is what it looks like intraoperatively. You just do a burr hole and you just tack it right, sew it right onto the dura. And then you can do post-op imaging and see where the 2 electrodes are on that person's middle frontal gyrus. I'm not going to go into this except to say that these were very treatment refractory patients, chronic, severe treatment refractory. They were pretty sick. They'd been ill on average 27 years, depression, had failed 10 treatments. 10 of the 12 had not responded to ECT. Current episode was 7 years long. And this is what the data looked like. So this is the Hamilton Depression Scale, and this is the MADRS. They track pretty closely. But you can see the light green is active and the dark green is sham. You can see a pretty marked difference here between active versus sham. And then if you follow out longer, this is now the light is 8 weeks, the data I just showed you, the active, and the green is at 16 weeks. You can see with time, you see further improvement of their depressive symptoms and also their global functioning improves. We did post-op imaging. We looked how far anterior we were from the precentral sulcus. So more anterior, the more forward it is within the gyrus. And we found that the more anterior the electrodes were placed, the greater the improvement in the depressive symptoms. That's as a continuous variable. As a categorical variable, we just cut it off at 20. And so the light blue is less than 20, so more posterior. Is greater than 20, so more anterior, and the green is less than 20, so more posterior. And you can see that the more anterior it was categorically as well. The response rates are now getting up to in the 40% range. We also did imaging here. We did baseline PET FDG, and then also did post-treatment FDG. And we found that the magnitude of decreased metabolism at the target, the left dorsolateral prefrontal cortex, correlated with the magnitude of improvement with active stimulation. So changes in glucose metabolism at the target tracked very closely to symptom improvement. I want to talk a little bit about ablative limbic system surgery. Here, I'll go through this relatively quickly as well. It's used for major depression and OCD, and I'll show you what the procedure looks like in a moment. They have to really, the take-home message here, they have to really not benefited from all conventional treatments. This is what the procedure, the lesions look like. This is a coronal view. You can see the two burr holes up here. So the patient has a stereotactic frame. Scalp is cut and retracted. Burr holes are drilled through the skull. And then via the frame, you can put an electrode any spot on the brain, XYZ coordinates within a millimeter or so. And for an ablative procedure, the electrode is completely insulated except for the tip. And when it's turned on, it heats up to about 80, 90 degrees Celsius. And in about 60 seconds, you get a 1 cubic centimeter lesion like this. Then you retract and repeat. So you can see it's right above the corpus callosum in the anterior cingulate. This is a sagittal view to give you, because the cingulate goes all the way from here to here, right? It's in the dorsal anterior cingulate cortex. We published data of cingulotomy for major depression. We took 33 consecutive patients at MGH who underwent cingulotomy. And at a mean follow-up of 30 months, 12 were responders and 12 were partial responders. So about 75% of patients received some benefit from this procedure, which is relatively remarkable, given that they had to have not benefited from all conventional treatments. The adverse events are minimal, they're not zero. Patients are usually awake when we do this procedure. The only part of the entire procedure that has any sensory innervation is the scalp, and the frame and the sutures are just done with lidocaine. Your skull doesn't have any sensation, and neither does your brain. So they're usually awake. They usually go home within 1 to 3 days. Anytime you do a craniotomy for any reason, put an aneurysm clip in, drain a hematoma, you have about a 1% risk of seizure and a 1% risk of infection. So those risks are no higher or lower than any other craniotomy. And we have done pre and post neuropsych testing on hundreds of patients who've underwent cingulotomy, have shown no decrements following the procedure. We also did baseline PET-FTG studies in these patients. And what we found, this is baseline, so preoperatively, we found the higher the activity in the pregenual cingulate cortex, which will be important later for DBS. It's one of the DBS targets for treatment-resistant depression. The higher activity at baseline you had, which is represented on the y-axis, at baseline, the greater the improvement in your OCD symptoms within 6 to 12 months. We also studied 64 patients, consecutive patients who underwent cingulotomy, but this time for OCD instead of for major depression. We found full response in 47% and partial response in 22%. So again, about 70% of these patients benefited. The procedure is the same as for depression, and the adverse events are the same as for depression. Here we did the same thing. We did baseline PET-FTG, and we found here, everything else is the same except the diagnoses. But here, higher activity in the posterior cingulate cortex, represented on the y-axis at baseline prior to the procedure, correlated with Y-box improvement. So just further back in the cingulum bundle, which we're ablating about right here. We'll talk a little bit about deep brain stimulation, and then move into future directions and leave about 15 minutes for questions. So deep brain stimulation, I'm guessing a lot of you are familiar with. There's now, I think we passed 200,000 people in the US have undergone deep brain stimulation for Parkinson's disease and other movement disorders. In psychiatry, we use the exact same hardware. The only difference is where we place the tips of these electrodes. So you can see here you have electrodes that go deep into the brain, thus deep brain stimulation, and they're connected by a wire under the skin, again, to a pacemaker on the chest that when they come in, I can program transcutaneously with a wand and a tablet, basically, to determine what the stimulation parameters look like. These are 4 of the first patients who underwent DBS at Mass General for psychiatric illness. This is from the mid-2000s. And you can see the electrodes, they go in And there are multiple contacts, which I'll show you in a second. There's 1, 2, 3, 4 contacts. And you can make any one of those positive or negative and shape the electrical field along the length of the electrode. Our target is what we started with at Mass General is called the ventral capsule, ventral striatum. It's in the anterior limb of the internal capsule and goes down into the striatum. Down here, once you get out of the white matter, this is nucleus accumbens. We do this because another ablative procedure, which I didn't talk about, called an anterior capsulotomy, is effective for OCD. It was developed at the Karolinska Institute in Sweden and done more in Europe than in the United States. But it's possible to place this deep brain stimulation electrode right at that anterior capsulotomy target. The anterior capsulotomy target is about the size of a pea, so it's much more amenable to putting an electrode in than these large 1 cubic centimeter lesions in the anterior cingulate. So that's why people went into the anterior limb of the internal capsule, including us. And this is what the electrode looks like. And it has 4 contacts, 0, 1, 2, and 3. This is ventral to dorsal. I don't know why it's not 1 to 4, but it's 0 to 3. And you can see this is work from Suzanne Haber, renowned neuroanatomist, tracing studies in primates. And you can see around contact 0 and 1, the gray matter on either side of the white matter, the internal capsule, the projections go to orbital and medial prefrontal cortex, which you recall the orbital frontal cortex was one of the key nodes in the pathophysiology of OCD. As you go up, the projections on either side are going to dorsolateral, and you get really high, it's motor and premotor. When we first started this work, we didn't know where depth-wise in the internal capsule we were going to get the most benefit, so we used this very large electrode to cover it all. Ultimately, we found that all of the improvement was in this hotspot around contact 0 and 1. So now we use an electrode that's about half as long. It might start here where I'm moving my cursor and go down to here. And it has 4 contacts, so it gives us better resolution within the hotspot, as it were. These are demographics that ultimately led to FDA approval of deep brain stimulation for intractable OCD. And this is what the data looks like. I would just look at the all subjects, the orange. You'd see after about 1 month of treatment, their Y boxes dropped by about 25%. And by week 3, it's down to close to 40 and stays down. This is out to 3 years. We have data way past that now. All pharmacotherapy and behavioral therapy trials of OCD define response as 35% or more improvement. And so this cohort is averaging response. Recent meta-analysis of the worldwide experience with deep brain stimulation for OCD, hundreds of patients now, shows response rates of 66%, which is remarkable. And of course, as their OCD symptoms go down, their functioning goes up, which is what this global assessment of functioning is. So it's approved by the FDA under a humanitarian device exemption mechanism in 2009. Humanitarian device exemption is kind of the device equivalent of an orphan drug approval, meaning it's not going to be used in a lot of patients, so you don't need as much data to get FDA approval. And it's routinely reimbursed by third-party payers. I was in the OR last Tuesday all day. We implanted a patient. We have another one scheduled for next month. So we're pretty busy with DBS for OCD. However, those OCD patients, 90% of them had comorbid depression, and that improved as well. So then we, along with Brown University and Cleveland Clinic, did a small open label study at the same target, but this time for depression. And here's what we found. Again, this is open label. We saw improvements, depending on which scale you use, of the mid-30s at 1 month, and then down to about 50% improvement that was sustained for the cohort on average. Again, 50% reduction in symptoms is the definition of response in depression. So 8 of the 15% were responders, and 5 of the 15 experienced full remission at 3 months follow-up. There were really no surgical adverse events. But the stimulation or lack thereof can cause adverse events. If we overstimulate, we can induce hypomania. And if the device malfunction turns off for some reason, the battery dies, the depression can worsen pretty precipitously. So based on this 15 patients, Medtronic, the maker of the device we were using for the ventral capsule ventral striatal target, did a large multi-site randomized controlled trial for FDA approval. The depression market is large enough that it doesn't qualify for a humanitarian device exemption, the orphan drug equivalent for devices. You have to do an active versus sham trial like VNS did. And it was negative. And it's been published now. I'm sorry. Here's that subgenual singular region we talked about earlier, that's but hyperactive in patients with depression, and also baseline activity in this region predicts who's going to respond to an anterior cingulotomy with depression. So Helen Mayberg and her colleagues went with this target, Broadman Area 25, and here you can see the electrodes. Again, it's 4 contacts, but they're putting it down in the white matter in the subgenual anterior cingulate. They published in Neuron a long time ago and found that 4 of 6 patients open label responded to treatment. They did it in much larger cohorts. Here's 17 patients, and they did others as well. There are a lot of open label data, and they found remarkable response and remission rates. Look here at 2 years, 92% response, 60% remission. Really remarkable. So great open label data, just like we had. However, they also did a large multi-site randomized controlled trial for potential FDA approval, and it failed as well. Other targets have been studied for depression. The nucleus accumbens, which I argue is pretty close to the ventral capsule ventral striatal target, but that's what they call it in Germany. Open label trial shows 5 of 10 TRD patients responded, but there's no controlled trials to date. And we've been fooled by good open label data in the past, as I just showed you. Perhaps more exciting from our colleagues in Germany is they've also started stimulation in the medial forebrain bundle. Here, 6 out of 7, their only open label data that I'm familiar with, met criteria for response, and it only took 7 days instead of the 3 months that we saw with the other targets. Again, it's initial proof of concept, no controlled trials to date. But I do know that those controlled trials are ongoing now, so we're hopeful. So future directions is how I want to end. What I've described before for DBS is put the electrode in, turn it on, leave it on. It's continuous stimulation. And we call that open loop DBS. It's kind of dumb DBS. It's just delivering constant stimulation. Closed loop DBS involves having electrodes in the brain that record brain activity, and then also electrodes that can stimulate. And what it can do is it can measure electrical signals that are tightly coupled with symptoms. And when it crosses a certain threshold or goes outside the guardrails, it'll deliver stimulation to move the electrophysiology signal back into the road, back into normal function, with the hope that symptoms will follow. So we call this closed loop as opposed to open loop. Other terms are adaptive DBS or responsive DBS. We did a large project funded by DARPA doing work at this closed loop, and we've developed a number of neuroalgorithms that of identifying a signal associated with symptoms, and then also developing a control algorithm, how to stimulate, which is also another whole pile of work, how to stimulate to normalize that signal. And we patented a lot of those. We're just waiting for the hardware to be able to do this in the brain. I've also recently been involved in transcranial focused ultrasound. We use a brain sonics device, and it has a transducer that looks like this, kind of like a hockey puck. And you can put it at the temporal window where the bone isn't very thick, and you can deliver these transducers come in different focal lengths. You can deliver ultrasound, low intensity ultrasound pulsations into brain targets. That's what it looks like. And there's somebody with it on the side of their head. Early studies, we found, this is studies that were published almost a decade ago. TFUS that's transcranial focused ultrasound, of the somatic sensory cortex can elicit tactile sensations. So even though people aren't being touched, they feel that they They feel that they are feeling something and enhanced sensory detection. Oops, let me get back onto this. We did a study in the amygdala, and what we found was if we stimulated the left amygdala, we found that we were able to decrease bold activity versus active versus sham with stimulation of that target, and saw the opposite in the hippocampus and the same in the insula, and no change in the dorsal anterior cingulate cortex. But at the target, most importantly, at the top, we showed amygdala suppression with TFUS of the amygdala. And we also found, before I go to the credits, we also found that their subjective fear response decreased with decreased activity in the amygdala following TFUS. So we're very interested. I wanted to show you how we're doing some of this stuff clinically, how we're using neuroimaging, which is you guys' bread and butter, to help us learn how these techniques work. But also, again, like I said, are interested in talking to anybody about collaborations. We're working with Bastion already, but maybe other people. The TFUS really calls for doing thermometry and perhaps ARFI in the magnet, and we hope to develop those types of things so we can really detect what's going on with transcranial ultrasound. But we're open to any other applications for any of the other device and surgical treatments that I described in this brief talk. This was really the primer, as it were, on psychiatric neurotherapeutics. So with that, I'd like to thank a bunch of colleagues and leave time for questions. Our Psychiatric Neurosurgery Committee, Ahmad Eskandar has left, and now it's Mark Richardson, Director of Functional Neurosurgery. We have psychiatrists, and we also have a neurologist. Todd Harrington has now joined. The morphometric analysis group has really helped. We're starting to implement tractography for targeting in our DBS patients, and also are looking at volumetric changes following procedures. Of course, the fMRI group, also the PET laboratory that we've worked with. We did most of our PET studies over at the main campus, but have been gradually moving them over here to the Martinos Center. And then our collaborators at all of the other sites that we work with to do these projects. So with that, I'd like to thank you. And there's Boston on a good day, hopefully a lot like today. So I'll close this up. I'll stop share. Great. And I'm happy to take any questions.